Okay, I'm now live. Hi, everybody. This is Thursday, April 30th. Tomorrow is May 1st, right? So may the force be with you or something like that. Or maybe that's May 4th. I can't remember. But regardless, may the force be with you every day in May and in April and whatever. Anyway, it's kind of a strange year, right, in terms of weather. Not that I'm the weather forecaster, but it's been like 40 degrees every morning, and tomorrow's May, so probably go to 90. Anyway, let's see. Hematuria, what can I tell you? The evaluation of hematuria is one of the most common things we do in radiology, particularly in CT. We do it in the ER setting. We do it from private offices. We do it in patients with known tumors, when you're staging a patient. There are a lot of reasons why we're looking for hematuria. If you, when you think about it, hematuria can be due to processes in the kidney, in the ureter, in the bladder, related to prostate. But typically we think about the kidneys as the place with hematuria. So in terms of protocols, what do? We always do a non-contrast scan because it could be stone disease. Sometimes with stone disease, you'll see a dilated ureter. It depends where the stone is, depends how large the stone is, depends if the stone is at the UV junction or the UP junction, and again, how large the stone is. Under 7 or 8 millimeters is likely to pass. Over 7 or 8 millimeters, it's likely not to pass, and so some intervention may be necessary. Hematuria is classically the most common presentation of a renal cell carcinoma, but we know that the majority of patients are actually picked up as an incidental finding. But hematuria is one of the things that we do look for, and we evaluate the kidneys for in patients who present with hematuria. What are we looking at? Again, I mentioned first and foremost ruling out stone disease. You want to look at renal size. Again, you can make up certain things, like you can see a mass, you can see suggestion of inflammation by changes in the peri-pararenal space on the non-contrast scan, but invariably you're going to give contrast. When I'm working up hematuria and the patient's over 40, I'll be doing arterial phase from diaphragm to symphysis. I want to make sure I don't miss a small bladder cancer, which can be tiny, but are typically hypervascular on the early phase imaging, and you can pick up bladder cancer smaller than 1 centimeter. We'll also then come back with a venous phase, typically to the crest. You don't typically need a venous phase, surely on a younger patient, through the pelvis, because if you had a bladder cancer, you would see it on the arterial phase. The venous phase is very good for looking at changes in cortical medullary differentiation that can be seen with infarcts, infection, or tumors. So that phase is critical. And so we're coming in about 30 seconds and about 70 seconds, and then it's 4 to 5 minutes for excretory phase. Excretory phase is very good for looking at the calyces, and so things like transitional cell carcinomas really need that excretory phase. It's good for looking at the ureters. You can see abnormal enhancement of the ureters, or see tumors involving or in the ureter, and then we'll follow it into bladder. As I mentioned, I like the bladder on the arterial phase because small tumors are vascular, but sometimes on the excretory phase you will see a tumor. But again, invariably you would have picked it up on the arterial phase. One thing to remember, if you're looking for tumors in the bladder, you could miss them as the contrast gets really dense, and so it can be a bit tricky to really diagnose all of them. In terms of interpretation of the images, we look carefully at the axial images. We then look carefully at multiplanar. I think coronals are particularly helpful. MIP is also very helpful, particularly for looking at the ureters or for looking with MIP imaging at the calyces, where you want to look for things like, all the different things that involve the calyces in the pelvis, ranging from tumors to infectious etiologies. And if you don't have the MIP imaging, you may miss it. I also don't want to scan it like 9 minutes or 10 minutes like people do. Then the contrast is too dense in the collecting system, and it's easy to obscure small lesions. When you're going at about 4 to 5 minutes, you'll see the changes in the calyces, in the pelvis, in the collecting system, and you'll be best at making the right diagnosis. I also mentioned that we look at axials and coronals and sagittals, but also MIP imaging is very important for looking at the calyces. I especially like MIP imaging when I'm looking at things like possible papillary necrosis or transitional cell carcinoma, anything which gives me a really good look and anything that makes me think about the calyces. Again, you could look at the ureters with MIP imaging as well. We'll also look at the ureters for stones, obstruction like tumor, also enhancement around the ureter. We talk about that as one of the signs of infection, and we had a great case showing that just a couple weeks ago. So those are the kind of things we think about. Obviously, you want to look carefully at the bladder. I mentioned arterial phase imaging, but also look at delayed phase imaging. It's often a trick to determine if the bladder is thickened and out. It depends how distended the bladder is. People tend to overcall, and the truth is no one really follows it because people say it so frequently. But if the bladder is really distended, then the thought of a small tumor in the distal ureter or in the pelvis of the bladder where tumors can be sitting, that's a possibility. And of course, the non-contrast is critical for looking at the presence or absence of calculi, which may be missed once you give contrast. I mentioned about axial and coronal and sagittal and 3D imaging, a combination of volume rendering and MIP, with MIP especially valuable when you're looking at the calyces, again, papillary necrosis, sponge kidney, but also transitional cell carcinoma are all things that become important. So that's a good start. I think we just released a bunch of new lectures on the kidneys. I think it's like a 5-part adventure with me. So take a look at that. If you have any questions, come back and ask us. Let me see on my comment list. I see Lydiana. Hey, Lydiana. I was in New York yesterday. Max had a thing at school, and then I was down by Whitney, and they had everything shut down because of the, I always say Prince Charles, now he's King Charles, but he was the prince so long, I can't remember that he's the king. Anyway, that took a little bit of, I took the subway back to the Penn Station. Those of you who have not been to New York in a while, the subway always was kind of a Amtrak station, always looked kind of like something from a bad movie. It looked like just did not look good, would be a nice way of putting it. And now they have a new Moynihan station, and that looks pretty cool. Hard to find a seat, that's the only thing. And they have a lot of restaurants, but I mean, you're going on the train, you're not looking to score a great meal, but they did a good job in fixing it up. Anyway, I usually don't take the train, I drive, but I did take the train. It was in and out, you know, but anyway. So with that, let me stop there. And again, any questions, take a look online. You can see the lectures, and if you go to CTisus, the teaching file, there is a lot of cases. And if you go to the pearls, there are a lot of pearls. And if you go to the quiz section, there are a lot of quizzes. And if you go to Lily's new section, there's a lot of pearls and keynotes on renal pathology. So with that, wish everybody a great day.